Thanks to the organizers for the opportunity to be able to present at this opening plenary. You know, when Bob was talking earlier, he talked about how unique our CF community is and talked about how we need to take some time to pause and appreciate in all that we have. I want to pick up that exact same theme for the talk tonight and to tell another story about our CF community, a story about how over the last 25 years, we've all drawn together, patients, family members, friends, caregivers, researchers, all drawn together to take on a great challenge. And in telling that story, I really want to bring home 3 points. First of all, hopefully that we'll appreciate more than ever what we have and what we've accomplished over these last 25 years. Also that we'll realize that we're getting a chance to live in really exciting and basically historic times as CF science gives us an opportunity to take on a genetic illness and defeat a disease. And lastly, that we would be more determined than ever to continue to make progress in this great challenge. So before I dive into this story, just wanted to give you my disclosures. These are all companies that I've worked, either received support for clinical trials or worked as a consultant for. And also to acknowledge that while I'm the one who's up here speaking, this really is a group effort. So that it's people at Johns Hopkins, it's people at the Cystic Fibrosis Foundation, other investigators, patients and their families, which makes this possible. So let's go ahead and start into our story. And we're going to start by going back 25 years ago. So 25 years ago, we knew that cystic fibrosis was a genetic illness, and we knew that it shortened the lives of people, of young people, but we didn't know the cause. But that changed completely on this day 25 years ago when there was the announcement of the discovery of the cystic fibrosis gene.
You can consider what has been accomplished here in an analogy of climbing a mountain. And this is a mountain that nobody's ever climbed before. And the top of the mountain is called having a treatment that cures this disease. What we've done and are talking about today is establishing a very prominent camp along that way, which allows us to look forward and have a much better idea of where we're going. But we don't know what chasms lie ahead, what cliffs, what rock walls. And since we're just beginning to glimpse the protein product of this gene, it's too soon to tell what it will take to give it a little boost to do what it's supposed to and cure the disease.
So 25 years ago, Francis used the analogy of climbing a mountain. He said, with this discovery, we basically have set a base camp at the foot of this mountain, and our challenge is to climb up this mountain, to basically defeat absent or non-functional CFTR, and to restore robust CFTR function. So what we're going to do for this talk is continue with that analogy and talk about our journey so far. We're going to talk about our progress in restoring CFTR function, and we're going to talk about the journey ahead, how we're going to climb to the summit to get to where we need to defeat this disease. We're going to talk about how we're going to restore robust CFTR function in all individuals with cystic fibrosis. So let's start by going over the basics again. Really, what's the basics of our challenge to make sure we're all on the same page? Remember that CFTR stands for the Cystic Fibrosis Transmembrane Conductance Regulator. This is a channel that acts as a chloride channel that lines most of the tubes of our body and plays a key role in balancing the salt and water and creating a protective liquid layer on our lungs. It acts as a bicarbonate channel and works closely with sodium channels to make sure that this airway surface liquid layer is healthy. So when working normally, we have this airway surface liquid that helps protect the lungs, allows ciliary function. This is all because of the function of CFTR in the apical membrane, and it's this balance with ENaC that works so well. Now, however, when CFTR doesn't work, whether it's non-functional or absent, we lose that chloride transport. We end up with this airway surface liquid layer that suddenly becomes dehydrated and thickened, and this very thick mucus lends itself to infection and inflammation. And this cycle of infection and inflammation leads to progressive airway destruction, which leads to the lung disease that we know can occur in cystic fibrosis. This is characterized by chronic bronchiectasis, progressive lung disease, because of a lack of CFTR function. Now, when I originally put this talk together, I had a nice slide here that looked at sort of survival curves and the effects of CFTR function. But as I thought about it, I thought this was a much better way, as we head into this talk, to think about what CFTR dysfunction really means. CFTR dysfunction means shortened lives. It's why it's so important that we take it on. And I think we can all think of individual patients whose lives have been shortened because of this. When I think of CFTR dysfunction, I think of Tyler, I think of Danny, Stacy, and Richard, all patients that I've taken care of. But I'm sure that we all have people that we can think of that are important in our own lives that have been affected by CFTR dysfunction. So let's talk about our journey so far in terms of restoring CFTR function and the progress that we've made. In any good journey, you need a map. And the map that we're going to use is a climber's map. It's a climber's map of Mount Everest, because our Mount Everest really is getting over this challenge and defeating CFTR or restoring CFTR. And so when we talked before and we heard that video from Francis, he said that the discovery of the gene was the equivalent of establishing a base camp at the foot of this mountain. So in our map, we're going to go ahead and place right now identification of CFTR in 1989 at the foot of this mountain. And then we're going to talk about the progress we've made using this climbing map. Now, when we look at this map, the thing that you might think is we're going to start talking about Camp 1 next. But if there's anybody in here who's climbed Mount Everest before, that you realize that actually there's a big challenge before you get to Camp 1. It's called the Khumbu Icefall. It's actually considered to be one of the most dangerous parts of the climb in Mount Everest, and it occurs just after you leave the base camp. It's almost as Francis knew about it when he described, he said, we may run into caverns and have to climb ice walls and all these things, because that's exactly what the Khumbu Icefall is, and it occurs just after leaving base camp. These are pictures of people crawling across the Khumbu Icefall. But the truth is we experienced something similar as a CF community in our journey, and that's because after originally having base camp identifying the gene, there was a lot of thought that we'll rush right up this mountain and get this done. But we quickly realized that this was more challenging and more complex, and it was going to take more time to figure this out. So I'm going to say that our Khumbu Icefall is actually understanding the complexity of CFTR and the classes of CFTR mutations, because it was essential that we spent time understanding that there was a diversity of problems with CFTR if we were going to really be able to understand and attack the underlying cause. So let's review real quick the things that we learned. We remember that normally CFTR is trafficked up through the cell and inserted in the apical membrane where it acts as a chloride channel, as we saw in the video earlier. But unfortunately with cystic fibrosis, there are several ways that this can go wrong. One of these is when there's a problem with the DNA that basically tells the ribosomes not to make a full-length protein, so there's no meaningful CFTR made. Class 2, the most common, are ones where a misfolding or a single amino acid missing leads to the cell recognizing that things are not right with CFTR and targeting it for degradation before it ever makes it up to the surface. And then there's the classes 3, 4, and 5, in which the protein makes it up to the surface but doesn't function normally, either because it doesn't open up, it doesn't transport chloride normally, or there's not enough of it at the cell surface. The importance of understanding this was that we could start to strategize how we were going to overcome this. And that led to this whole idea of potentiators and correctors, with the idea that potentiators would be drugs that we could open up those channels that were already at the surface and increase the amount of chloride, so those classes 3, 4, and 5. Whereas correctors were specifically for one where there was no CFTR up at the surface, particularly class 2, where we could try to increase the amount of CFTR that gets up to the surface to increase chloride transport. Well, this looks great in a little slide presentation, and we used to talk about it all the time at different presentations, but there was always this question is, would it really work in anything besides cells? Would it make a difference in patients? And that's why the first experience with identifying ivacaftor and its benefit in G551D mutations was so important. And that's because for the first time we were really able to demonstrate that yes, this makes a difference. As you recall, ivacaftor is this potentiator which opens the channel up for class 3 mutations and originally was worked on just for patients who had a single G551D mutation. What we picture going on here is that the ivacaftor binds to the protein already present at the surface, opens up, increases that opening time, restores that chloride transport. there was another big part of this when this was published. So in 2010 and 2011, when these papers were published, obviously it was wonderful news for that 4.4% of patients who carried a G551D mutation. But there was something even bigger about this and made it so historic. It was the first time that we really were actually able to demonstrate that restoring CFTR function was going to make a dramatic difference in clinical outcomes for individuals with CF, right? So we'd always thought, hey, what we need to do is to fix chloride channels. But it was really with this that we were able to say that when we fix this channel, when we restore chloride transport, patients get better. The other thing that was so impressive about this is that it gives us the ability now to continue to study all the effects of restoring CFTR function. And we're learning some of the new things that we never realized before. So let's go through what we've learned about what happens when we restore CFTR function, because this is really telling us as we climb up this mountain, as we restore more CFTR for more patients, what we're going to be seeing. The first is that we know now that restoring CFTR function results in improved FEV1. These are the data from the original ivacaftor study in G551D patients. You can see that 10% improvement in absolute FEV1 during that first study period, and that continued improvement in the rollover period. I'm going to highlight, though, another thing that's being presented at these meetings by Greg Sawicki and colleagues, and that is there's evidence now that restoring CFTR function actually decreases the rate of decline in FEV1. So if we look here, what we see is two different lines. And what Greg and his colleagues did was to look in the cystic fibrosis registry over a 3-year period and compare the rate of decline for patients with G551D taking ivacaftor with those who were F508del homozygotes. And what he found was that the rate of decline was less than half when you were taking CFTR correction with ivacaftor. So it wasn't just a one-time bump up at the beginning of taking this drug, but over years continued to slow the rate of decline, which is an essential point. Now that may not look all that impressive in this graph, but I want to show you this figure that I put together. And this is looking at that rate of decline that was predicted and looking at this over a lifetime. So this would be the rate of decline seen so far in patients who are taking ivacaftor and comparing those F508del patients who are not on CFTR modulation. So that during a period beginning at an early age with starting to a period in the 40s, the difference is between having good lung function and actually needing a lung transplant because of end-stage lung disease. So not only does it maintain lung function, but it literally adds potentially decades of life. And at the end of this very long, ripe life, still not reaching this age requiring lung transplantation. So highlighting the potential effect of changing the rate of decline of lung function. The other thing that we've learned now is that restoring CFTR function reduces hospitalizations. So this is work from the GOAL study led by Steve Rowe and colleagues. And this was specifically looking at the effects on hospitalizations in the 6 months and 12 months before, the 12 months before starting ivacaftor, the 6 months before ivacaftor, and the 6 and 12 months after ivacaftor. And the take-home message is that restoring CFTR with ivacaftor dramatically reduced the frequency in which patients were hospitalized. The same thing is that we're beginning to realize that restoring CFTR can decrease Pseudomonas aeruginosa culture rate. The exact same design here, where we have the 12 months before ivacaftor, 6 months before ivacaftor, 6 and 12 months after. And the thing that we always thought really wasn't possible, that is to reverse chronic Pseudomonas, at least there's a decrease in the frequency of these patients culturing Pseudomonas when they had it before. So this is something that's very exciting that sort of makes us think the earlier we can start patients in this, the better, but it affects microbiology, not just lung function. There's also growing evidence that restoring CFTR function improves BMI and improves nutritional status in general. So this is looking at data from both the ivacaftor studies and the GOAL studies, that in both kids and in older individuals, that in that time after beginning CFTR modulation, there was a significant increase in BMI. And this is not just, again, a one-time thing. This is the other analysis being presented by Greg Sawicki at this meeting, in which this rate of weight gain is different over time and not just as a one-time thing as we restore CFTR function. And we're beginning to learn new things about CFTR. One of these that I think is particularly interesting is this paper that was published recently by Dan Gelfand and colleagues as part of the GOAL study, which looks at the effect of restoring CFTR function in small bowel pH. So I'll just run you through this because it's a little bit complicated, but this is pH scale on the side, and this is actually the pH of the small bowel lumen over time after a meal. And that normally, if we want to optimize digestion and the effect of enzymes, we would like to have that pH be in this very narrow range represented by these two lines. Now, unfortunately, when we do not have CFTR restoration, this is not the case. We actually have a much more acidic lumen than we normally would, and this is not inside the range of optimal nutrition. But when we restore CFTR, that pH is actually improved. This is going to improve nutrition. It's going to improve the efficacy of enzymes, and it highlights one of the new things that we're learning about the many attributes of CFTR. I'm going to highlight one other thing that I think is particularly important, and this is being presented at this meeting by Jane Davies. This is an open-label study of ivacaftor in young patients, so patients that have G551D mutations or other gating mutations between the ages of 2 and 5. Remember that right now this is only approved for patients age 6 and above, but we would love to get it into this younger group if we knew it was safe. So please go see the workshop for all the details. Jane's going to be talking about that on Saturday, but I'm going to highlight some of the key findings. The bottom line is that ivacaftor in this group was well tolerated in the 34 children who took it for 6 months. There was a little bit higher rate of elevated LFTs, so if this ends up being approved in this younger group, that may be something we want to pay a little extra attention to. But it really showed the same type of effects that we've come to see with ivacaftor and gating mutations, a significant decrease in sweat chloride and a significant increase in weight for age. There's no FEV1 data here, obviously, because it's hard to get a 2-year-old to do PFTs, although I'm sure we'll figure out a way. Let's talk about one other thing that's actually particularly exciting. This is from that same presentation that Jane's going to be doing. This is suggesting that there may be a role for restoring pancreatic status if we're able to restore CFTR function at a young age. I'm going to lead you through this slide. So fecal elastase is a way of measuring in stool the amount of enzymes that have been released by the pancreas to help with digestion. And what we normally think is that if the amount of fecal elastase in your stool is below 100, it means that you have severe pancreatic insufficiency. If you're between 100 and 200, you probably have moderate pancreatic insufficiency. If you're above 200, you probably have some residual pancreatic function. The interesting thing is at the start of this study in these young 2 to 5-year-olds, all of these patients had fecal elastases within this severe group. But over the course of the study, a significant portion of them showed some restoration of their pancreatic status. This is something that's really not been expected. It highlights how important it may be to try to begin treating patients early and perhaps being able to preserve some of that pancreatic status that we thought was already gone. So you can see as we go through our climbing map that it's obvious that Camp 1 is ivacaftor for G551D. This was a landmark. This is clearly where we really are saying, hey, we're starting to ascend and get towards the summit and a clear area that we need to mark on our map. The good news is that we found that. The bad news is that, unfortunately, as we know, only about 4.4% of our patients have G551D. So the question is, how can we continue to climb up and get more patients be covered with CFTR restoration? Because right now we're only talking about 4.4% and not covering the other 95.6%. Well, let's talk about that. One of the easy ways, or for the first steps to be able to do this, is to get ivacaftor and be able to demonstrate that it's beneficial in other mutation classes. And so the first obvious one is to take other mutations that are almost identical to G551D, for instance, the class 3 mutations. And by increasing coverage to that group, that would give us another 1% or so. Then the next step would be if we could take ivacaftor and show that it was beneficial for any of these mutations where the protein's already up at the surface, because that would allow us to suddenly get about 15% of patients with monotherapy with ivacaftor. So let's go through some of the data now that talks about and shows that ivacaftor is likely going to be beneficial in these groups. So this is the trial in which we studied patients with ivacaftor alone, with patients that had mutations that were nearly or very similar to G551D, what we call non-G551D gating mutations. The protein's up at the surface, but it doesn't want to open up. It was clear in this group, and the other mutations that were studied include the ones listed down here, that the effects in this group were basically identical to what we'd seen in G551D, an 11% absolute improvement in FEV1 during the first 8 weeks. During the rollover period, we see continued benefit with a net improvement in absolute FEV1 of nearly 13% in this non-gating. So this group was recently approved by the FDA and is now eligible because it's clear that this group benefits as well. So this gives us a few more patients to be able to be covered. The next group that we're working on now is the R117H mutation. This is another mutation where the protein's sitting up at the surface with the potential to be opened up. I'm going to tell you that this is an ongoing story, and it's a little bit complicated, so I'm going to lead you through this. This was the original trial in which we took patients that were children, adults, mixed them all together with R117H and did the typical placebo-controlled trial. And at the end of this trial, the primary endpoint was not statistically significant. It was only 2.1% absolute change. So after a little bit of sort of hemming and hawing, we looked closer and actually began to realize that what had happened was that the people who didn't improve in this were people who already had very good lung function, up at 90 or 100% or greater. And they really didn't have a lot of room to improve. But when you actually looked at patients who took this, who had lung disease, patients who were over the age of 18, it was clear that they had benefit. They had an absolute change in their FEV1 of 5 percentage points during the study. During the rollover period, they continued to show benefit. You can see that right here, they have that 5% difference, that they, during washout, lost that benefit. Then during rollover again, both they and the group that had been in placebo had improvement in their lung function with instillation of ivacaftor. So this is a drug which is going to be reviewed by the FDA in the next month or two. Obviously, they're going to be the final judge. But I think that we're beginning to get more and more evidence that that ivacaftor is going to be beneficial in R117H. Now, how about that last group, the classes 4 and 5 in particular, where the proteins up there that we haven't talked about that are not G551D or R117H? There was a very slick study that's being presented by Jerry Nick and colleagues at this meeting, which was called the N of 1 residual function study. And it looks a little complicated, so I'll lead you through this. But the bottom line is they took patients who had this protein up at the surface, class 4 and 5 mutations, who had pancreatic sufficiency or had low sweat chloride, suggesting they still had some residual function. And they did, rather than a typical placebo and treatment arms, they did a study where they used each patient as their own control. So what they did was basically just go on and off drug and compare how they did when they were on drug to how they did when they were off of drug. And so as you look at this right here, you see this would be a 2-week cycle on ivacaftor, 2 weeks on placebo, then they would take a month off, then they would do this again, obviously getting a bunch of assessments each time, washout, and then they would have this 8-week period on ivacaftor, and then again another washout period. They did this because they knew that they could group all the data together in one way, but it would also allow them to go back and look at individual mutations to see if there were specific mutations that they just didn't group all together, but that they were able to identify and look at some of the function. Let's look at some of the results. The bottom line is that there's evidence that ivacaftor works in these residual function patients as well. So when you look during the 2-week cycles for these patients, what they had was an absolute improvement in their FEV1 of 2.1%, which was statistically significant, a relative change of 4% during just the 2-week periods. And then during these 8-week periods, had a 5% improvement in absolute FEV1 and an 8% relative improvement. All of this really makes us think that there's going to be a very good chance that we're going to be able to cover 15% of our patients with just ivacaftor. So that sounds great, but that still means that we have 84.5% of our patients, so we need to keep climbing. And how are we going to be able to really make a difference and try to get that number, that remaining number down? We all know that the way to do that is by attacking the class 2 mutations, right? Because almost 90% of individuals with cystic fibrosis have at least one F508del mutation. So let's talk about that now. One of the things, first of all, is to realize that within that class 2 and that F508del, it's about 47% of patients that carry 2 of those mutations, and about 39% that carry a single F508del. So we're going to attack and talk about those each separately. Remember what the F508del effect is. We talked about this earlier, but just as a reminder, so normally CFTR is trafficked up to the surface. When you have F508del, what you end up having is lack of transfer of that protein up to the surface, so there's no chloride channel up there to be able to turn on. So in order to be able to address this, we need to use correctors. And the corrector that we've been studying in particular over these past few years is lumacaftor. Lumacaftor is a CFTR corrector that in F508del moves CFTR to the surface. And so this is just looking at cell culture studies, what the effect is. So that we know that in cells, F508del cells, that with no drug, they have very little chloride transport. With the addition of lumacaftor, they actually have more chloride, more CFTR up to the surface and additional chloride transport. And then if we add in that potentiator, ivacaftor on top, we're actually able to get about 25% of the normally expected chloride transport. So this is great. This looks super in the dish, and it's all been very exciting. But the real question is, what was the effect going to be in patients? And that's probably the most exciting thing that's happened over this past year, was that as a CF community, we completed 2 very large phase 3 studies of this ivacaftor-lumacaftor combination in patients who are homozygous for F508del. Now, this was a massive undertaking. This is actually a list of all the different names of people that were included in this, so this is a real international effort. But the key results are going to be presented by Claire Wainwright at a symposium on Friday. I'd encourage you to go ahead and attend that to get all the details or visit one of the posters. But what I'm going to do is to highlight some of the top-line results and to show why this is so exciting. So the design of these 2 studies called Traffic and Transport, and these 2 studies were nearly identical. The reason we had 2 nearly identical studies is because of regulatory requirements to have 2 positive studies in order to have a drug approved. But the eligibility criteria for this were, it was age greater than 12, had to have CF, obviously, homozygous, so 2 of the F508del mutations, and an FEV1 between 40 and 90%. And then once they were enrolled, they were randomized into one of 3 treatment arms, either placebo, lumacaftor 600 milligram once a day in combination with ivacaftor 250 milligrams twice a day, or lumacaftor 400 milligrams twice a day and ivacaftor 250 milligrams twice a day. So this was a big study. This is over 1,000 patients from all around the world and over 100 centers participating in this. Let's go through some of the, I'm going to actually present the pooled data rather than present each study individually, so we can actually get out of here in a decent amount of time. That the pooled data is very powerful, but I can tell you that both of these studies showed the exact same thing. So these pooled data, we had over about 370 patients in each of these study arms, that in terms of their characteristics, they were amazingly well balanced in each study arm, so that age was around 25 years, age groups about 75% adults, 25% kids. The FEV1 was around 60%, so pretty significant lung disease, and BMI almost identical at 21. Now this is the results from the primary outcome of the pooled data from the lumacaftor, ivacaftor, and delta F508 homozygotes. And what it showed was a clear benefit in FEV1 over the 6 months of the study, with an initial quick improvement in that first 2 weeks and persistence of that improvement across time. Now this was a moderate effect. When we look at the exact numbers in terms of this pooled data, we're talking about an absolute change in FEV1 of around 3%, a relative change and improvement of around 5%. But I can tell you as investigators, we're absolutely confident that this is a real and important effect. And I just wanted to show you one sensitivity analysis that we were all impressed by and sort of even made us more convinced about this whole benefit. It's hard to read, it's not meant to read it, but really what we did as investigators is to say, if we split up all these patients into different characteristics that might influence the way they respond, what do we see? Now in this slide I'll lead you through that basically there's this black line right here. If your FEV1 result for your group is to the right of this black line, that means that even in that subgroup you benefited from this combination. If you're to the left of this line, it means that you didn't show benefit. No matter how we slice this group up, by age, by gender, by what other drugs they were taking, by their microbiology, the patients showed a clear and consistent benefit in FEV1. And it really wasn't just FEV1 that we found most impressive. It was effect on pulmonary exacerbations. It's clear that lumacaftor and ivacaftor together reduces the number of pulmonary exacerbations. So we're probably all familiar with this type of graph, but this is basically the y-axis tells us the percentage of patients who have not had an exacerbation. So everybody starts up here, no one's had an exacerbation, and over time you can see as people have exacerbations, that numbers decrease. What's clear from this, as you can see, is that the placebo group had significantly more exacerbations during the 6 months compared to both treatment arms. When you quantify that reduction, it meant that there was about a 30% reduction in the number of exacerbations with the 600 milligram dose, and nearly a 40% reduction in number of pulmonary exacerbations for the 400 twice a day dose. This was also supported by other secondary outcomes, which included things like events requiring hospitalizations. You can see this dramatic decrease in the treatment arms, and nearly 60, or actually an over 60% reduction in the 400 twice a day in hospitalizations, a 50% reduction in the frequency of needing IV antibiotics when on combination therapy. There was also some evidence of modest benefit in BMI, obviously clearly a statistically significant difference, and about a 0.2 to 0.3 difference in BMI for patients who were taking combination therapy. Now, how about safety and tolerability? Because obviously this is just as important as the efficacy data. The take-home message is that the lumacaftor-ivacaftor combination is safe and appears tolerable. That there's a couple specifics, though, I want to go through that I think that are worth discussing. When you look at the number of patients who experienced any adverse event, it's basically identical across the board, really no difference in the total number of AEs. When you look at the patients who discontinued due to an AE, there was a little bit higher, about 1 or 2% higher than placebo in the patients on treatment. However, if you looked at those who experienced serious AEs, it was much higher in the placebo group, really probably because of all the increased exacerbations and hospitalizations there. When you look through the rest of this, all these other AEs, they basically were perfectly balanced, or just about perfectly balanced between both groups with two exceptions. One was this infective pulmonary exacerbation, the benefit we've already seen with treatment. The other was in a subset of patients, perhaps about 3 to 5% of patients more than placebo, who when they first started this combination experienced some dyspnea or what we call respiration abnormal or chest tightness. So at that very first point, it may sense some of this. Now this was usually moderate, it was self-limiting, and I think the key thing is to realize that all that great data, the outcomes data that we showed you included all these patients, because this was an intention to treat analysis. So the key thing is that while there is a small subset of patients who may experience this at the beginning, it's clear that even with this, they have an improvement in their FEV1, they have less exacerbations, less time in the hospital, all the things that we're hoping to achieve. The other thing that makes us confident about these results are some of the initial results from the rollover study. So at the end of this phase 3 study, patients were offered the opportunity to roll over to open label, which meant that if they were on 600 milligrams a day, they would stay on 600 milligrams a day. If they were on 400 twice a day, they would stay on 400 twice a day. If they were on placebo, they would be randomized to one of the two treatment arms, although they're blinded as to which one it is. These are the data from the rollover study, which basically show the exact same results we've already seen in the phase 3. So this is the data we just looked at. At the beginning of the rollover, we see this placebo group immediately showing benefit and coming up and looking similar to the patients who are on treatment. I will say it's easy to try to get focused on this last group where there's more variability, but I'll highlight that this is actually only 25% of the patients. There's more variability, a smaller group. The data that we're really confident about are the data that are listed here, which really highlights that both in that phase 3 and in the rollover, we see this significant FEV1 effect. In terms of safety profile for the open label, we've basically seen the same thing, so no surprises there, again making us more confident about the results. So what are the upcoming plans for the lumacaftor-ivacaftor combination for F508del homozygotes? We know that there's plans for a new drug application for this combination in the fourth quarter of 2014. It was announced this morning that the dose that's going to be selected is that 400 milligrams twice a day in combination with ivacaftor, 250 milligrams twice a day, based on that dramatic decrease in pulmonary exacerbations. We're continuing to gain data, both in safety and efficacy on the open label rollover study. And there will be an open label study in F508del homozygous patients with FEV1 less than 40%. It'd be tempting just to suddenly say, let's give this to everybody. It looks very promising. But I think as investigators, what we said is we really have only a little bit of data in patients less than 40%. We would like to get some additional data in these patients as well before we start giving this to everybody. And so those are planned over the next few months. So this has potential to really increase the number of patients that we're covering, right, with CFTR modulation. This would give us over 60% of patients who would potentially benefit from modulation. So as we look at our climbing map, I think it's clear that our next camp has to be lumacaftor and ivacaftor for F508del homozygous, because it allows us to increase so much the number of patients who are covered by CFTR modulation. And that brings us really to where we are now. So on October 9th, 2014, in Atlanta, this is where we are on this climbing map. But we know that we still have a lot more to climb. So let's talk about what we need to do to continue to attack that remaining 38.6% of patients and to get some CFTR modulation for all patients with cystic fibrosis. We know that one of the ways we can figure out the map that we need to follow is by looking at who's remaining. And there's two big groups that are remaining. One of these are the F508del heterozygotes, patients who have a single F508del allele. This is about 30% of those patients, and they're not covered by any of the other things that we've already talked about. And then about 8% of patients who have two of those class 1 mutations, which we'll talk about. So as we look at our climbing map, we really say that our next couple of camps that we have to head to, one would be CFTR correction for heterozygous F508del, single alleles, CFTR restoration for class 1 mutations, but then we realize that we're still not close to the summit, because our summit really is actually restoring robust CFTR function for all mutations. So really increasing the amount of CFTR correction that we see. So let's talk about how we're going to continue to push forward here. One of the first things we might think about is to say, hey, why don't we just use lumacaftor and ivacaftor in patients with a single F508del allele? Well, we've tried that, and these data are being presented by Steve Rowe at these meetings at poster 254. The bottom line is that, unfortunately, lumacaftor, ivacaftor doesn't appear strong enough by itself to improve FEV1 in patients with just a single F508del allele. We can see there wasn't a significant difference in FEV1 in this phase 2 trial compared to placebo. But there was actually one very interesting and somewhat encouraging finding, and that was that most recent study included sweat chloride. And it turns out that lumacaftor, ivacaftor actually does reduce sweat chloride in F508del heterozygotes. It was actually 11 millimole decrease in these 62 patients. This suggests that we're getting close, right? There's clearly some CFTR modulation going on. So whether it's a little bit of tweaking or perhaps a little bit stronger agent, a little bit stronger corrector, it means we're getting close. The CFTR corrector that we're going to likely be working on next, which has potential to be able to take on and include these F508del heterozygotes, is VX661. So VX661 is a corrector that works with a similar mechanism to lumacaftor to traffic F508del CFTR to the cell surface, as we've talked about before. It has a longer half-life, it has less drug-drug interactions than lumacaftor, and there's been no evidence so far of some of that early chest tightness that we talked about before. I'm going to present some of the data that Scott Donaldson presented at the European meetings this summer, which shows the effect of VX661. This is in homozygotes right now, but it's going to sort of build why this may be helpful in heterozygotes. And we can see that in the 100 milligram and the 150 milligram dose, there was a significant improvement in FEV1, a 9% relative improvement, an 8%, or nearly an 8% relative improvement in the 150 milligram dose while on combination therapy for 28 days. That improvement went away when discontinuing drug, and obviously was significantly better than placebo. But there's some other data that are being presented at this meeting which I think are particularly intriguing and suggest to us that perhaps VX661 can be helpful in heterozygous patients. So I'm going to lead you through this because it potentially get a little bit confusing here. These are data that Joe Paluski is presenting at the symposium on Friday. This was looking at the effect of ivacaftor and VX661 in patients who have F508del on one allele and G551D on the other. So this is a group of G551D patients who are already taking ivacaftor. And the question is, if we add VX661 to them, do they show additional benefit? Additional benefit because we're able to actually increase the amount of CFTR modulation through that single F508del allele. And I think the findings are actually very encouraging. During those first 28 days, when VX-661 was added on to ivacaftor, there was an absolute improvement in FEV1 of 5% on top of what they'd already had an improvement for with ivacaftor. This was a 7% relative change. They had a continued improvement in sweat chloride, again, on top of what had been seen from the improvement with ivacaftor, and an improvement in CFQR. When this was discontinued, the VX-661 was removed, they went back to exactly the place they'd been before. Their FEV1 change was resolved, their sweat chloride went back up again, their CFQR went back down. So I think this tells us two things. One is that our VX-661 has potential to be able to affect a single CFTR F508del allele. The other is it also highlights that even though ivacaftor is such a great success story with G551D, there's potential for even more. These patients continue to show even more benefit with adding a little bit more CFTR correction to their other allele. So this, hopefully in the future, will help us in this journey to be able to cover all of these class 2 mutations and get us more into that 90% or more of patients to be covered by this. But we know in order to get all the patients, we're going to have to take on class 1. As you recall, class 1 is more challenging, right? Class 1 includes patients who have stop codons where no protein's made. It also includes chromosomal deletions and canonical splice mutations, and none of these result in meaningful protein being made. As you recall, what we think happens with the most common problem in class 1 is that the stop codons cause the ribosome to stop making protein and disengage before the full-length CFTR is made. Our thought about the best way to be able to attack this is by developing read-through agents, agents which would tell the ribosome to keep going despite that faulty stop codon and to make that full-length CFTR protein. Our most promising read-through agent to date has been adelorin. And these are not new data, these are data from the year before, but they highlight what's going to be coming up. Remember, as you recall, this was a phase 3 study in adelorin specifically for patients who had these stop codons. And what they found during this trial was while there was a trend to improvement in FEV1, the primary endpoint did not reach statistical significance, which meant this was not an approvable drug. However, an analysis afterwards showed a very interesting thing. And that was if patients were not taking inhaled antibiotics, particularly inhaled aminoglycosides, during the trial, they did have a significant improvement in FEV1 of around 7%, again, statistically significant. It was patients who were taking inhaled antibiotics and inhaled aminoglycosides that really did not show benefit. The reason this is interesting is we know that there's potential that aminoglycosides may inhibit the effects of adelorin as a read-through agent. So, in this upcoming year, PTC is now initiating an adelorin phase 3 efficacy and safety trial in patients, and they're not going to be taking inhaled aminoglycosides to see whether or not we're able to reproduce this effect and hopefully use this as an agent for patients that have class 1 mutations. The other thing that I should mention is that there are some trials that are going on which would address not only the stop codons, but everything within class 1. That is, they would actually replace the gene itself. We were hoping to be able to present the results from the UK gene therapy trial. This is a trial that basically all genotypes were eligible for. The treatment was with nebulized liposome-based gene delivery. These patients would get 12 nebulized doses at monthly intervals. 115 patients have enrolled in this trial and received more than 9 doses. Unfortunately, the data aren't quite ready yet, but we're hopefully to either hear about those results in late 2014 or in early 2015 from Eric Alton and his group. This would be another approach which would allow us to be able to get all patients and get to that part of the mountain where we say we have some CFTR modulation for all individuals with cystic fibrosis. But how are we going to get to the summit? We really said that our summit is not just sort of covering everybody, but getting robust CFTR function for all individuals with cystic fibrosis. So in order to really understand how we're going to do this, I think it's essential to sort of think about what's the most effective way to do this. If you think about it, the best way to really jack up that robust and get to that robust period would be if we could increase the amount of CFTR correction for F508del, because about 90% of our patients have one of those mutations. And in order to understand how we're going to do this and do the next generation of correctors, it's important to understand how basic CFTR biology works. So this would be the ribosome making normal CFTR protein. So this is normal CFTR, and normally as the amino acids come off, this forms a three-dimensional structure with different domains, the transmembrane domains, the nucleotide binding domains, and these fit together basically like puzzle pieces. And so we have TMD1, TMD2, NBD1, and it turns out these puzzle pieces, where they fit together is exactly where the phenylalanine in the 508th position is, right in this key area where TMD1, TMD2, and NBD1 fit together. And that's why when we have problems in that area, is we have such problems with CFTR. But it also highlights where we have to target for our next generations to fix this. So when that all fits together, the puzzle pieces fit together well, this traffics up to the surface and everything works well. But what happens when we remove that phenylalanine? So F508del, which basically means we pull out that phenylalanine, a single amino acid, suddenly those puzzle pieces don't work together as well. Interactions are broken, the transmembrane domains pop out, the nucleotide binding domains is now less stable, and the cell recognizes that this is not correct, even though the CFTR protein isn't there, and it targets it for degradation. We're beginning to realize that the way the correctors work is by stabilizing those interactions right in that critical area. So correctors such as lumacaftor and VX661 correct folding of CFTR by stabilizing the interaction between NBD1, TMD1, and TMD2. And while we've seen clearly that it does some stabilization, we're beginning to realize that we may need more than one corrector to get the amount of stabilization and the amount of trafficking that we want to get robust function. Now, there's some evidence that we are going to be able to develop some of these other correctors, and we're starting to see this in labs all around the country right now in developing other correctors. These are some data that out of Fred Van Goor's lab looking at the effects of additional correctors on the ivacaftor-lumacaftor combination. So we've already seen the ivacaftor-lumacaftor combination may give us 25% of wild type. But if we're able to add a second corrector that targets a different area within that crucial interactions, that can stabilize the CFTR even more, get more to the surface, and get 50, 60, even 70% or more of the expected chloride transport that we're going to need to see to get robust function. Again, this is all in cell culture. We also see the exact same effect in carrying a single F508del allele. So really, when we think about this, and it's actually not just one lab, I'll say. So the other labs around the country have been finding the same thing. This is from another paper that was published in 2013. This is just saying that on top of lumacaftor, which is what VX809 is, that adding additional correctors can give us 3 or 5 times the effect that we see with lumacaftor alone. So in the future, sort of the next generation that you hear talked about, the next generation of CFTR correctors are going to target different parts of the F508del CFTR right in that crucial area to further stabilize CFTR folding and dramatically increase the amount of CFTR traffic to the cell surface. So let's take a look at what we think this is going to look like. So right now we say that F508del doesn't fit together. We bring in that first corrector, something like lumacaftor or VX661. That fits right in this area and stabilizes this folding and allows some of those puzzle pieces to fit together again. But we still have some instability. Additional corrector, next generation correctors are going to fit in other parts of F508del CFTR, stabilize this even more, and make this a corrected F508del that's ready for trafficking to the cell surface. Once it's ready for trafficking, we're going to have more of these individual channels. They're going to traffic through the cell, as we're going to see here, in greater numbers than we've seen before. They're going to head to the cell surface. Once there, they're going to be inserted into the apical membrane lining the surface of the lung. The first corrector and the second correctors are going to have that be a more stable and functional CFTR, and then we're going to potentiate that even more with ivacaftor or other future potentiators to get that robust CFTR function and chloride transport that we're aiming for. The good news is this isn't just a pipe dream. This is something we know that's going to happen. There's actually 12 different companies right now that are convinced that this is going to work. It's just a question of who gets there first. So all of these companies right now are in their labs working on new correctors, new potentiators to do exactly what we were just watching in the video. The other thing I'll say is that there's other technologies out there that may allow restoring robust CFTR function that actually don't even deal with CFTR. They deal with the CFTR gene. So at future plenary sessions, we may be hearing about technology which actually repairs the gene. And obviously, this would be something that would allow us to get robust function for all individuals with CF. So this brings us to our final slide, our original climbing map. So 25 years ago, when Francis Collins and all the investigators identified the CFTR gene, they put a base camp at the foot of the mountain and said, this is the mountain that we need to climb. And there's the summit at the top, restoring robust CFTR function for all mutations, which is going to help us defeat this disease. 25 years later, it's clear that we've made great progress in this. And as a matter of fact, we seem to be gaining momentum as we get closer to the top. There's no doubt that we're going to get to the top, and we're going to reach this goal of restoring robust CFTR function for all mutations. But the thing that makes this so exciting, the thing that makes this so worthwhile, is I think that everyone would agree that while we say our goal is to restore robust CFTR function for all mutations, we know our real goal is to restore robust life for all individuals with cystic fibrosis. So as we leave this plenary and we head to other meetings for the rest of the week, as we head back afterwards to our jobs, to our labs, whether we're a patient in a clinical trial, we're a family member or a friend who's supporting an individual with CF, we're a caregiver who's staying late at night after clinic, or a researcher who's working on the most cutting-edge CFTR modulator, let's ask ourselves, are we doing everything we can to help us get to the top of this mountain? Because I can tell you there's not going to be any other opportunities in life that would be better than this to contribute and make a difference to such a meaningful and worthwhile cause. So with that, I'd say thank you for all of your hard work, thank you for your dedication, and thank you for your attention.